All good. Good afternoon, everyone.
Good afternoon. Good afternoon.
Sangeeta, audible അല്ലേ?
Good afternoon, sir.
Good afternoon. So today, let's learn about the management of gastrointestinal symptoms. Today, I'll be concentrating mainly on nausea and vomiting. I will be having another session on the rest of the symptoms. So before starting, let's discuss about this. Mr. X, he drank 2 liters of beer. So there are 3 situations he started vomiting. So we have 3 different times. In half an hour, a few hours later at the night, and tomorrow morning. So he came to you that he was vomiting and you want to manage him, give some antibiotics for him. Will there be any difference in the medicine that you give to him at these 3 times? Hello?
Yes, you are audible.
Hello?
Dr. Arjun, you are audible.
Sister, am I audible?
Yes, you are.
Hello?
Hello, Dr. Arjun. Can you hear us?
Which medicine will you give to this person?
Can anyone please respond?
Okay. Yes, antiemetic. Which antiemetics will you give? Will you give same antiemetics at the all 3 conditions, or will you have multiple tablets and multiple? So if we came to your situation, is the audio clear now?
Yes, you are audible.
Okay, Madam Bharati, which tablet, which medication will you give if this person comes to you in half an hour? Audio still an issue?
So some chatter coming up, order strong.
Okay, thank you. Okay, ondansetron, yes. Okay. So ondansetron are 3 times, all the time when he comes in half an hour, maybe a few hours later and tomorrow morning. Any other answers you want to fill up? Okay. So there is difference as the antiemetic that you give it in different types because injection, yes, that's ondansetron. Injection Panto, yes, that's another drug. So
Dr. Arjun, we can hear you, or maybe their issue something. So you can
there are
continue.
multiple comments saying audio issues are there. Are my clear better now?
Yes, you are audible. You can continue. If they have any problem, we will deal. No problem. You can continue the session.
Okay, thank you, Shivas. So the aim of this session is to identify which medication you have to administer at the time of when the patient presents with a nausea or vomiting. That would be the final takeaway home message at the end of this session. So moving forward, what is emesis? Emesis is a biological defense mechanism to remove the toxic or harmful substances after ingestion. So it can happen through three processes. One is nausea, retching, and vomiting.
Vomiting, sir.
The vomiting, the emesis is a process. So it happens through three steps. Like one is nausea, retching, and vomiting. So what are these? Nausea is an unpleasant feeling of need to vomit. So the contents may not come out. It's a feeling of needing to vomit. Which is the most common symptom, most undistressing symptom among the symptoms that we face in a palliative care OPD or among the palliative care patients. And it's often accompanied by autonomic symptoms like pallor, cold sweats, salivation, and tachycardia. So nausea is just an unpleasant feeling of needing to vomit. The patient will say, I have a feeling of vomiting, but I'm not vomiting. Then vomiting is a forceful expulsion of gastric contents through mouth associated with contraction of abdominal and chest muscles. So the contents in the abdomen is forcefully expulsed through the mouth associated with contraction of muscles. The abdomen and chest muscles contract together and forces the gastric contents outside. That's vomiting. What's retching? It's a spasmodic respiratory movement against a closed glottis with contraction of abdominal muscle without expulsion of gastric contents. So there is the difference between retching and vomiting is here their abdominal it's against a closed glottis. So the gastric contents is not expulsed, but the feeling, the contraction happens. The gastric contents try to come out, but it against the glottis and goes back. That's stretching. If it comes out with the open glottis, it's vomiting. And regurgitation, it's an act by which food is brought back to mouth without abdominal or the diaphragmatic muscular activity. So that's different from vomiting is because the muscles are not pushing it, it comes normally. Like in case of a small child, after the feeding, the infants, after feeding, we burp them, or what? They will regurgitate. So there, the abdominal or the diaphragm muscles are not causing this emesis. So that's why regurgitation. When the abdominal muscles work and it comes out, it's vomiting. If it doesn't come out, it's retching. And the simple sensation of need to vomit is nausea. I hope you understood the difference between all the four terms. So vomiting can be at multiple types. Acute, which can occur in few minutes to hours, which usually results in 24 hours time. Or it could be delayed, which usually occurs after 24 hours. Often that we see post chemotherapy. Like the patient will start vomiting in after 24 hours. The patient comes today, takes chemotherapy, goes home, and after next day he starts vomiting, which might get worse in next 2 days. It can even last to 6 to 7 days. So another thing is breakthrough. Breakthrough vomiting is when even after the vomiting this happens, even after an antiemetic therapy is treated. The patient is already on an antiemetic, suitable antiemetic, but the patient still has vomiting episodes. That's a breakthrough vomiting. Refractory is it is not responding to any antiemetic regimens. The normal medications the patient is taking for vomiting and it's not responding, and patient gives vomiting. That's a refractory vomiting. The most next thing is anticipatory vomiting, which the patient it's a conditioned response we usually see prior to the chemo. Like an event, the patient might believe that this thing is going to cause vomiting, and the patient vomits before even the like the patient is started for chemotherapy tomorrow, and the patient comes to the chemo room before even starting the medicine. Like even the stimulus has applied, patient will start vomiting. It's patient anticipates vomiting, and he starts vomiting. That's called anticipatory vomiting. So what effects does vomiting has, nausea and vomiting has on patients? This I want to hear from you. So you might have seen patients with severe vomiting or nausea coming to you. What all things do you think these symptoms can have on patients?
The patients, it is frustrating. Also, it causes dehydration sometimes, as well as they're unable to take any food, so it can cause retained food, so nutritional immediate effect, like they can have hypoglycemia and low energy, and also irritation, gastric irritation because of frequent vomiting.
Yes, thank you for the excellent answer. You covered a large number of issues that you see. And to add on to your, we have like distress, burning sensations, excessive salivation. So many studies has happened in all over the world, and vomiting, nausea is not only associated along with cancer patients, even with non-cancer patients. All these studies show that the range of distress, nausea and vomiting ranges from 6 to 68%. So such a distressing symptom these are. And the patient is already tired, and more vomiting means the patient has more exertion and he gets more tired. So poor control of other symptoms. The patient may not be able to take medications. Even the medicines they take will be vomited out. So poor control of the other symptoms, like if the patient has pain and patient is on morphine and patient starts vomiting, every time patient takes the morphine, the vomits out. That means the pain medication doesn't reach the body, so symptom control is not achieved. Aerials are affected. The activities of daily life may not be able to be done by a patient with severe vomiting. He may not be able to eat his own food or walk to the toilet or do anything by himself. Decrease food intake. Definitely, the patient won't be able to take more food. One thing is that it could be the food, the smell of the food or the sight of the food can be distressing, or even patient might be afraid if you take more food that will cause more vomiting and more distress. So the patient will stop taking food, which will add on to their other distresses. As you said, dehydration, electrolyte imbalances can happen, adverse drug reactions. The quality of life is totally tampered. The patient won't be able to have a dignified life, period of life with these symptoms. He cannot go out or meet someone, go to a function, because he is having severe vomiting. And non-compliance of treatment, very big issue that we face. The patient might be in good response to chemotherapy or any other medications, the patient will understand that these drugs are causing the vomiting and patient will stop. So what happens? The treatment failure happens. Many a times when we see patients on pain medications on especially on opioids, they come back with severe pain because they stopped the medication because of vomiting. So the pain recurs and worsens, and they come back. Refusal of effective analgesia, as I already said, the pain medications may not be able to work. The family is distress. The entire family will be seeing this and be in severe distress. So the types, the causes there are multiple causes of vomiting, which can be chemically induced. Some chemical changes that could be causing the vomiting, like the drugs, the opioids, antibiotics, cytotoxins like the chemotherapy drugs. Sorry. Or other toxins which may be due to the food poisoning, ischemic bowel, gut obstruction, metabolic organ failure. These could cause chemical changes which can lead to vomiting. Same time, anticholinergic drugs, opioids, again, ascites, peptic acid ulcitis, which may be worsened by the stress drugs or even post-radiotherapy. Gastric stasis can happen, like the gastric movement may be obstructed, which can also lead to vomiting. Then the constipation, intestinal obstruction, mesenteric metastasis, metastasis of the mesenteric lymph nodes or different area, which can also cause stretching of the gastrointestinal tract and can lead to vomiting. Liver metastasis and urinary obstruction, which can cause serosal irritation, which also leads to vomiting. Infection, drugs like NSAIDs, ibuprofen, diclofenac, or even presence of blood in a severe gastric ulcer, these things can cause irritate the gastric tract. So the body will try to expel the irritating thing and cause vomiting. Increase intracranial pressure, the cerebral edema, or space occupying lesions, intracranial bleeds, or infections affecting the brain or meninges, which can also cause irritation and cause vomiting. Movement associated, the vestibular disorder, the most common thing, the travel sickness, motion sickness. You get on a vehicle, you sit there, start vomiting once the vehicle starts moving. Anxiety induced. As I already explained, the anticipatory vomiting or anxiety, which may definitely you may feel like vomiting when you're too anxious. Or the environmental causes like the vision or the sight or smell of food or lack of cleanliness or even distaste. All these things can worsen can lead to nausea or vomiting. So this is important that you know how the patient, what is causing the patient's vomiting. Only then you can have a good symptom control. So here there are multiple, so as I already explained, there are multiple reasons which can cause the symptoms. And these symptoms activate certain receptors on certain parts of the our body, which leads to the emesis. Like anxiety can activate the cerebral cortex, which leads to the emesis. Otherwise, the drugs, including chemotherapy, which may act on the chemoreceptor triggers on the CTZ, which consists of the area portion as auditory tract nucleus in the brain, which can send signals to the brain and cause emesis. While motion sickness acts on vestibular system. See, the point you have to see this is the motion sickness is not activating cerebral cortex or CTs. It acts on the vestibular system, which leads to vomiting. And likewise, we have multiple receptors on the gut, which could be caused by the functional gastric stasis, hepatomegaly, intestinal obstruction, radiotherapy, chemotherapy. So you see the colors. These colors shows the presence of these receptors in there. So these stimulus, like if it start the patient on chemotherapy, the drugs could activate the yellow and red receptors, as in the picture, which can the serotonin receptors and dopamine receptors, which leads to emesis. So when you want to treat that patient, you need to give a medicine which can stop this action. Like the serotonin receptor and dopamine receptor has to be stopped. But you don't need a receptor, which a medication which could be acting on a vestibular system, because that system is not the one which is get activating when chemotherapy is doing. So ideal drug has to be chosen, which has to be given to the patient for symptom control. This is the idea that you have to have after the session. So give me some non-pharmacological management that you can advise your patient, which does not involve any medications. What all we can say to our patients if they complain of severe vomiting?
Sucking on an ice cube or washing mouth.
Okay, many a times like poor hygiene in the oral cavity can cause vomiting. Yes, so that could happen. And sucking on ice, yes, to an extent, it's more effective in obstructions. Avoid triggering elements. Definitely, the old triggering. Drink lemon sugar water. Sugar seems to be a little more irritant in case of vomiting. For some people, it won't be a choice for vomiting. Psychological support, hygiene, very good. That's it. No more. Counter anxiety. Yes. Anxiety. The patient is very anxious, might be anxious. So there, if the patient is anxiety is causing vomiting, yes, we will have to manage with the anxiety.
Sometimes the site of like the environment has to be cleaned. Previous vomiting trace or food that is food waste, etc., kept around them sometimes can be a trigger. That needs to be even other sensory stimuli need to be reduced. Sometimes pain or maybe allodynia kind of pain, etc. That also can cause. So maybe that need to be also taken care.
I totally agree with you, ma'am. Yes, so we can see the patient might be having multiple episodes of vomiting. His waste products could be all over his body, the dress, the linen, or the floor. The food particles might be there. So it is something that can worsen the vomiting. So that has to be clean. Fresh clothes has to be given. And you said one point which no one said: the pain. Pain can worsen vomiting, and vomiting can worsen the pain. It's a cycle. It's like a cycle. So that has to be managed. Avoid caffeine and alcohol. Agreed. Rest is very important for these people. They'll be too tired.
I also think another point, sleep deprivation at times, disturbance can also add to the sensation of vomiting discomfort.
Yes, sleep deprivation, that could add on to their distress. So adequate rest has to be given. So fresh air. Okay, eat small and frequent diet. Yes. So fresh air, bed rest to avoid vestibular stimulation. So the movement can, at times, vestibular stimulation can happen. So vomiting can worsen from another side. Good oropharyngeal hygiene. Meaning often the patient might be vomiting, or there could be thrush or some other fungal infection, which could be worsening the vomiting. So maintaining good oropharyngeal hygiene. Halitosis could be the foul smell, which could be due to some infection or some oral pathology, which can worsen the vomiting. So a good oropharyngeal care hygiene is needed. Always nurse them in their upright position. We don't want them to, even bedbound patients, we don't want them to feed them in a lying position. Nutritional advice, yes, try to eat small frequent meals rather than 3 large meals. The patient, as we usually do in our house, we might feed them the breakfast, lunch, and dinner, which will be large meals. This the patient may, the poor patient may not be able to take, because could be multiple reasons. The gastric stasis could be there, but for them, a small meals at frequent intervals could be a right choice rather than giving a large breakfast. If you divide the breakfast into 3, give one portion at 8 o'clock, 10. Okay, if we are taking 3 idlis, okay, one idli at 8 o'clock, he's happy. He happily takes that, and he doesn't want anymore. Okay, let's wait till 10 o'clock and give him another idli. Okay, he may be able to take the small meal, and such way break down the meals, small meals and frequent intervals. That could be one big change that you can suggest. And consume most foods during the time of the day when they are able to eat better. So there could be at their time, like, people would be able to take much but more food. They feel like they are more hungry, so give them the maximum food at that time. Usually we see at breakfast time is seen as most like most people find that breakfast time is the best, and give them foods and drinks which are easy on the stomach. So there are which are very easily digestible, less fiber. The fiber contents might worsen, delay the digestion. So, such without less fiber, less spicy, not too very sweet, not very fatty food. So easily digestible things. And do not force them to eat when they're nauseated. This is something that we have to talk to every one of our family. In our country, unfortunately, we show love by force feeding you. We feed the people to show love. But a person who is already nauseated, force feeding them is something which is very worst thing that you can do to him. He already is nauseated, he want to vomit, but the family might be saying he's not taking food. The family may not ask him why he is nauseated, but their family will try to force feed him. And what happens is the vomiting can get worse. Then rather than the hot food, cold food or at room temperature foods, which are better tolerated. And avoid carbonated drinks. So some people say the carbonated drinks can can improve the gastric status. So, but avoid them. More irritant they are. And what if the one who is making the food is having the nausea and vomiting? He or she may not be able to tolerate the smell or even the sight of the food. So I make someone else to make the food. And even for some people who are having special diets, like a diabetic or heart disease patient, their dietary requirements should be relaxed. He's already vomiting, he's lacking his daily needs. So relaxations has to be given to him. Let him eat the dish which he might prefer, he might like, and the way the amount he likes at the time he likes. And getting a dietitian consultation would be a good thing if they could help you better in such a situation. Keep the mouth clean and do oral care after each episode of vomiting. Wear loose-fitting clothes, have fresh air with a fan or open window. Don't put them in a closed room, or you need fresh air. You need to keep the room without any odors. Limit sound, sights, and smell which can cause nausea and vomiting. Those are irritant environmental factors which can worsen the vomiting, so avoid them. And make sure that you always give a contact information if the symptoms can worsen. Still not getting control, give them a contact number where they can have a contact. Call you or your office or your IP or OP room when they have uncontrolled symptoms for help. So we have discussed about the different centers of that causes the vomiting. So and also the receptors which active. Now we should know also know the medications which can help the patient at this time, like the chemoreceptor triggers on CT set have dopamine and serotonin symptoms, which is getting worse through drugs, metabolic effects or toxins. For them, the drugs of choice would be the haloperidol, metoclopramide, and especially for chemotherapy drugs, ondansetron, granisetron would be a good choice. So this is important that you know what the patient is causing vomiting to the patient, and adequate medicine. This medicine right for the patient has to be chosen. That is why the importance of knowing this. Like a patient with glioma comes with severe vomiting and altered sensation. The patient, the vomiting would be due to raised intracranial pressure. For him, a medication which can reduce intracranial pressure is to be given, like a cyclosin or levomethrin could be beneficial for them. For a patient who comes with severe vomiting after chemotherapy, for him a serotonin antagonist should be given, like an ondansetron or granisetron. At the time when a patient comes with opioid, due to the patient started on opioid comes with severe vomiting, for him haloperidol is a drug of choice because it acts on the chemoreceptors. So that's choosing an antiemetic. Identify the cause. Identify what is causing the vomiting. Identify the pathway which triggers vomiting reflex. So when a patient comes to you says he's vomiting, don't just give him off with ondansetron or metoclopramide or the drug alone. You think what is causing the vomiting, correct the correctables, and give the adequate medicine. Okay. So identify the neurotransmitter receptor involved, choose a potent antagonist to the receptor identified, and route of administration. The patient, you usually give a tablet, but is the patient in the status to take a tablet? That's a question you have to assess before giving the prescription. He will be too vomited, too much vomiting, then he cannot take anything orally. For him, an alternate route might be needed. And intravenous or subcutaneous or transdermal patches are available, or even soluble sublingual patches are available. So the route has to be decided. So someone coming with severe bowel obstruction, he might even he will so dehydrated that we might not even get a IV line. For such a patient, a subcutaneous medication administration can be done. Titrate the doses, monitor patient, and administer regularly. So medicine has to cover the patient's symptoms throughout the day so that the patient can have good symptom control throughout the clock. So the most common available antiemetics that we use are anticholinergics like hyoscine, dicyclamine, D2 blockers, chlorpromazine, prokinetics, metoclopramide, domperidone. Apiripine is available in some parts of the country. It's kind of costly one. Promethazine, diphenhydramine. 5-HT is the ondansetron, granisetron, very commonly used in for chemotherapy. And adjunct antiemetics, which doesn't have an antiemetic action in the line, but they support antiemetic action, like dexamethasone, benzodiazepines. This is a clinical picture, like a patient with a metabolic or biochemical upset which is causing the vomiting. The patient usually persons with a persistent or severe vomiting, and little leaf will be having from between the vomiting. So usually the site irritated will be the CT set, the chemoreceptor zone. So which could be caused by the drugs or carcinomatosis, chronic inflammation, metabolic changes. For that patient, the drug of choice would be haloperidol or metoclopramide. And motility issues, there may be intermittent large volume vomiting. Symptom might leave temporarily. Early satiety, the patient might feel feeling of a fullness of stomach with small quantities, reflex hiccups, and little nausea until immediately prior to vomiting. Usually the gut receptors are more sensitive. For them, motility, so one thing, prokinetic would be much better for them. Metoclopramide and domperidone would be the choices. And see, erythromycin is an antibiotic which has a potent prokinetic effect that usually we don't use unless others are not working. So erythromycin can also. Then sometimes it could be due to a tumor which could be in the abdominal area, which could be causing obstruction. The motility can be blocked by the tumor. So I see ovary, the large tumor could be obstructing the bowel. For there, dexamethasone would be the ideal choice of drug because dexamethasone can reduce the peritumor edema around the tumor. In size, it does not reduce the size of the tumor, but it can, for some time, reduce the edema around the tumor and give some motility. So dexamethasone can be tried. But the dose thing is a long-term continuation is not always beneficial. So we will have to reduce the dose or taper the dose accordingly. Even in refractory cases, we will have to continue at a lowest possible dose, which is clinically beneficial. Otherwise, the patient might have to go for a surgical intervention where a stent has to be placed at the obstruction site. Intracranial disorders, increased intracranial pressure, usually presents with severe headache, altered conscious level, usually seen in intracranial space occupying lesions or tumors. For them, cyclosin can be given, hyoscine. From them also dexamethasone can help because dexamethasone is one drug which can help reduce the intracranial pressure. For inner ear issues, cinnarizine would be a good choice. In gastric irritation, so gastric or esophageal irritation, there will be constant nausea versus on eating. Colics could be there, usually due to the stimulation of vagus. Could be tumor, toxin, or infection. Even candidiasis can be causing. So in case of candidiasis, we deal with many patients who are very immunocompromised. So for them, oral candidiasis, which might extend into the esophagus, is very common. So for them, antifungal would be the drug there needed, or gastric irritation, which might be caused by some antibiotic or some other things. Even the steroids can worsen that. For them, the PPIs or the ranitidine, the proton pump inhibitors, the pantoprazole, those drugs will be beneficial for them. Yeah, remember, prokinetics like the metoclopramide or domperidone can worsen the esophageal spasm in such conditions, so they have to be avoided. Many times there will be multifactorial or unknown causes or refractory, other things that would be causing. For them, dexamethasone could be given, even if it's an anxiety issue or such issues. Ideal drug would be benzodiazepines. Lorazepam 0.5 to 1 milligram of diazepam would be the drug of choices in such situations. So most common adverse effects that we see is for the ondansetron is most commonly prescribed medication among us. Unfortunately, the symptoms, adverse effects that we can see is that headache, constipation, which many of our patients will be presenting with constipation. You add on ondansetron, which may not be beneficial to the patient, but it will add on to the constipation, thereby increasing the distress. So please give the medication at the right for the right cause and the right medication at the time. Then dopamine receptor antagonists, those can lead to extrapyramidal symptoms and akathisia, anticholinergics, antihistamines, which can lead to confusion, sedation, dry mouth, blurred vision, even urinary retention. So have an attention to the hydration and nutritional status. Nausea often can be cause of lack of efficacy of antiemetics. So a patient who is already on antiemetics come to you back with certain complaints of nausea, reassess the cause, make sure that you're giving the right medication, titrate the dose or change the drugs if you need it. So that could also be a reason cause the nausea persisting. Then if it could be refractory, try benzodiazepines. If you think that's an anticipatory or anxiety-induced one. And prokinetics, please watch. They might trigger esophageal spasm, abdominal spasm. So a patient with colicky abdominal pain comes to you with severe vomiting. Do not give prokinetics because it can worsen the spasm. Even severe complete obstruction and all. Partial obstruction, which is going to be taken in the next session. Partial obstruction, the gut motility may be reduced. Such situation, prokinetic can help them. So increasing the gut motility, the constipation can be managed, thereby reducing the symptoms of partial obstruction. But if it's a complete obstruction or if the patient has a complaint of severe bowel obstruction, colicky pain, prokinetics should be avoided and it can cause spasm and more worsen the pain. So make sure it's not there. So relaxation can help as anxiety can worsen the vomiting. Continue pain medications as pain versus the vomiting. So it's a cycle. The pain can worsen vomiting, vomiting can worsen the pain. So make sure the pain medications are continued. The patient comes with severe vomiting, change the route of oral medication until the vomiting is controlled. Make sure the patient gets enough analgesics through subcutaneous or parectal or any other routes. Small portions of food more frequently, plenty of fresh air. To summarize, always evaluate, manage, monitor, and assure. Okay, always evaluate for the causes, manage the issue that is causing the vomiting or nausea, monitor the patient whether they are getting improved, assure that the symptom control is attained. So when it's come to management, always correct the correctables. Non-pharmacological management has a very good role, very important role in this symptom management. So make sure you advise this non-pharmacological management to each and every one of the patients you're seeing, choosing the right pharmacological management and interventions. Make sure you address all the physical, psychological, spiritual, and functional concerns of the patient. So Oxford textbook of Pallium is a good reference for this. So two questions, like one, Ms. Vasha, she had Hodgkin's lymphoma, has severe vomiting, even at the site of oncology one. So when she comes to chemotherapy, she was good responding to chemotherapy. She comes for the chemotherapy tomorrow morning. And by the time she steps into the ward, she starts vomiting. The medicine has not yet been started, not even the IV line, but she starts vomiting with this by entering this. So what drug will you give Varsha? So which is the drug that we can suggest for Varsha? The reference book is Oxford textbook of palliative medicine.
So Bharati said metoclopramide.
Yes, metoclopramide. I don't think that. So. Haloperidol.
Sunitha ma'am said haloperidol.
Here, Vasha started vomiting right before the trigger stimulus. The actual stimulus is the medication, the chemotherapy drug. but she started vomiting right at the entry of the room because she was anxious. She had an anticipated vomiting. She anticipated the vomiting episode and she started vomiting. There was no actual stimulus there. So the drug of choice would be benzodiazepines. Her vomiting is more of an anxiety issue, so that has to be managed with the benzodiazepines. Ondansetron, domperidone, haloperidol, metoprolol won't be able to help her there because anxiety is causing the reason. The correctable reason, the cause of the vomiting is anxiety. So the drug of choice for that is benzodiazepine, a lorazepam or a diazepine, which can be given on the day before so that an anxiety stays down and she doesn't vomit. No other serotonin receptors or other dopamine receptors are not being activated here. So this is why this importance of knowing the cause of the vomiting. The second person, the Madhavi Amma, with advanced cancer ovary and constipation 1 week duration, has vomiting since 2 days. So remind, she is an advanced carcinoma ovary. She has constipation and vomiting. So which will be the drug you have to give for Madhavi Amma?
Domperidone.
Okay, so a abdominal cancer patient comes with constipation and vomiting. You suspect bowel obstruction. Yes. Prokinetics might help. Yes. Because she hasn't made a complaint of bowel obstruction. Sorry, colicky pain. Then domperidone can be given, but it's a constipation of 1 week. So if she has not passed any even flatus, I can consider as complete obstruction, where we may not use prokinetics, but it can cause spasms. So if it's a partial obstruction, I would say domperidone. Same with metoclopramide, domperidone, metoclopramide, both are prokinetics. So the ovarian cancer, the tumor might be causing the obstruction. It might be pressing to the bowel. So which medicine will you give? Dexamethasone, yes. So it can reduce the periotumor edema and release the relieve the obstruction. So thank you, Sundar madam. So moving on to the first question. So Mr. X came with 2 liters of beer. So he started vomiting in half an hour. So let's take 3 situations. So in half an hour, what happens? He started vomiting. What could be the reason he started vomiting in half an hour? Gastric irritation might take little more time. It's a sudden symptom that occurs. So more probably that with gastric stasis or a large, around 2 liters of the alcohol has reached the stomach. So it can be causing gastric stasis or distension. So what we want is it to be emptied from the stomach at full time. So which drug can facilitate movement of the contents? How does? which drug do you think would be helping to move the contents out of the stomach? Not ondansetron. Ondansetron might be helping for attention, but here what we want is to move. We need a prokinetic to improve the movement of the fluid or the contents from the stomach. So they might benefit from a metoclopramide or domperidone. So moving on at night. So after a few hours, the way he has vomiting, which could be due to the toxins might be affecting the CT set, the chemoreceptors on, the CT sets on. So there, the drug of choice would be there also. Haloperidol would be a good choice, or even metoclopramide. And it has when it happens due to the metabolic changes which affect the CT cell. Then tomorrow morning, if the patient starts vomiting on the next day, that's usually to the gastric irritation. So which drug will you give if he's vomiting of gastric irritation? Dexa is more a gastric irritated drug. That's why with steroids, we always give some other medications to avoid the gastric irritation, dexamethasone, NSAID. Which drug will you suggest for avoiding gastric irritation?
पेंटाप्रामाजोल
Madam?
सर पेंटाप्रामाजोल दे सकते हैं
Yes,
रेंटेक
pantoprazole. Yes, pantoprazole could help you, or ranitidine, all those things. The proton pump inhibitors would be the drug of choice for this situation. So thank you. Now we are open for questions.
Thank you, Dr. Arjun.
Mr. Shiva, if there
Yes,
are
yes, yeah. Okay, thank you, Dr. Arjun, for the wonderful session. Anybody have any doubts on this? Please ask now. Otherwise, we can move on to the case presentation. Anybody have any questions or clarification? So I think it's clear to everyone. No more questions. We can move on to the case presentation. Mamta.
Okay.
Mamta will be presenting a patient story today. Ms. Mamta, so over to you.
मैम हेलो
Yes.
मैम एक क्वेश्चन है जैसे हम कैंसर डिपार्टमेंट में नहीं कर रहे अभी जो जैसे कैंसर डिपार्टमेंट में मेडिकेशन नहीं करा पेशेंट नहीं देख रहे जैसे जर्नल काम कर रहे हैं पेशेंट्स के ऊपर तो उनकी जो मेडिकेशन है जैसे पॉइंट्स देना और उनकी डोजेस उनमें बड़ा कंफ्यूजन है असाइनमेंट जो सेकंड है उसमें जो क्वेश्चन है ना उनमें कंफ्यूजन हो रहा है मैम उनमें मतलब हमें डोजेस का नहीं समझ आ रही कैसे देना है आंसर उनके क्योंकि जिस डिपार्टमेंट में आप वो काम करते हो उसी वही मेडिसिन आपको ज्यादा अच्छे से आता है, चाहे वो गायनी में, ऑप्स में कर रहे हैं, मेडिसिन में या सर्जिकल में। तो कैंसर डिपार्टमेंट का थोड़ा इसमें मेडिसिन का वो रह रहा है डोजेस में।
So you are talking about the assignments, right?
हेलो,
Yeah, Sister Devinder, you are talking about the assignments or today's case presentation?
नहीं टुडे वाला तो मैम सॉरी, आज मेरे को फीवर था और मैंने मेडिसिन लिया तो मैं अटेंड नहीं कर पाई क्लास, तो अभी मैंने
Can you
खोला
talk
है
in,
ये ज्वाइन।
please?
तो मैं कर रही हूँ असाइनमेंट नंबर 2 का जो
Okay, okay. Mamta, we need to take the case presentation now. So Mamta will be presenting a patient story now, and if you have any difficulty on any assignments, we will take it later. So now we are moving on to the case presentation. Mamta,
Yes, ma'am.
yeah, you can present now.
Okay, ma'am.
Can you able to see the slides?
Yes, ma'am.
Yeah, Mamta, you can start. Is it visible?
Yes, ma'am.
Okay, you can start now.
Ma'am, 76-year-old female patient with complaint of CA pancreas with liver mets, and the presenting complaint is joint pain in abdomen, weight loss, poor appetite, nausea and vomiting, liver enlargement and constipation. And the history of patient is a 76-year-old woman having complaints of abdominal pain from the last 3 years. Due to her financial circumstances, she can't take a proper treatment. A couple of months back, the pain can't tolerate. Then she went to hospital and done all routine investigations like blood, urine, ultrasonography, abdomen, and biopsy. Then she diagnosed as a CA pancreas. After the surgery, she stopped all kind of medicine and not interested to take chemotherapy and radiotherapy due to financial crisis. General condition of patient is patient look weak, paler, and anemic. Temperature is 98.6 degree Fahrenheit. Pulse is 86 beat per minute. Respiration is 18 beat per minute. BP is 170 mm of Hg, and oxygen saturation is 96%. Investigation and treatment is palliative care, regular community visit at her home, analgesia, antiemetic, and laxatives. And psychological aspects is financial crisis, family issues, spiritual issues, feeling hopelessness, fear of death, feeling that she is a burden to the family. And the medication is tablet pantoprazole 40 mg, BD, tablet morphine 5 mg, 4 hourly, tablet tramadol 50 mg, TDS, tablet paracetamol 500 mg, TDS, tablet Bicasul OD, and syrup is Siramifin plus night में. Main concern about pain management, constipation, emotional distress of the patient. And the summary is a 76-year-old woman diagnosed as a CA pancreas with liver mets, presenting with abdominal pain, pain management done along with addressing the psychological issues. And discussion point is what are the ways of reducing pain, sorry. What is the importance of non-pharmacological pain management and gastrointestinal symptom? how can the family be involved in all management and solve financial crisis?
Okay, thank you, Mamta, for the wonderful presentation. Anybody need any more clarification regarding this patient story? Please ask to Mamta. Anybody? So I hope this presentation is clear to everyone. Can
So
you
let
go
us
back to
start. I
the
think we can go for the
medication history, right? Medication chart.
yes.
Yes, yeah. So we would like to, from the participant side, our pain session is over. Now we move on to the gastrointestinal symptoms. Please tell us, is there any modification needed for this prescription? Everyone, please respond. This patient is on tab pantoprazole 40 milligram BD, tab morphine 5 milligram 4 hourly, tab tramadol 50 milligram TID, tab paracetamol 500 milligram TID, tab Decosuls OD, syrup cramafin plus HS. So our question is there any modification needed for that prescription? Dr. Arjun, do you want to ask any other questions from this?
No, I want the same clarification on this. I would
Okay.
like to hear from the participants their opinion on the medications advice.
Anybody can respond, please.
I have a question, pain assessment, a little more details, please, because I don't know if morphine 5 mg fourth-hourly, is there any rationale it needs to be increased? I just wanted to clarify.
Okay. Mamta, madam is asking whether this patient is need morphine for her pain. So that is she needs the pain score and all. So do you have a pain assessment details?
Yes, ma'am. I can pain assessment chart.
Okay, please tell us, just share with us what was the patient's pain, what was the score, and what was the type of pain, and when did you start morphine and on?
Actually, ma'am, I am working in government sector. So हमारे पास कोई भी वो नहीं होती कि जिससे हम पेशेंट का कर सकें. हमने वैसे ही पेशेंट को असेस किया जिससे लगा कि पेशेंट खुद कंप्लेन कर रहा था कि उसको पेन है. तब हमने उसको ऑब्जर्व किया.
Okay. So when did you start morphine for this patient? Mamta, Shani ma'am,
Yes, ma'am.
apart from that questions, is there any modification needed for this? Any modification or any drug you want to add or any drug you want to stop? Any others also you can think about.
No, actually, Shiba ma'am, actually, I have to get a little more familiar with the drug combination part of it. I'll have to read a little more because I understood, but it has to register in my head a little bit. Sorry.
Okay, so we had actually learned about the WHO analgesic ladder, right? So WHO analgesic ladder, step 1, step 2, and step 3. Step 1 is a non-opioids, that is paracetamol and NSAID plus or minus adjuvants. And step 2 is weak opioid, the opioids for mild to moderate pain, that is tramadol. Okay, so if the patient is not getting adequate pain relief with tramadol, that is weak opioids, so you should stop tramadol and start morphine. Don't combine weak opioids and strong opioids together. We should usually we should stop tramadol and then we start morphine. And also we have to think about the dalcolax, that stimulant laxatives. But because one of the most common cause of constipation, the side effect of constipation is side effect of morphine is constipation. So that patient need a stimulant laxative. Here, this patient is not taking any stimulant laxatives. Because of that, maybe these patients can develop constipation. So this patient need an stimulant laxatives, example Talcolax or sodium pycosulfate or something like that. And also you have to take a proper history also. Dr. Arjun, you want to add
Yes,
anything?
yes, I want to add something. Starting from the pain assessment. So you have already gone to the session for the pain, the PQRST assessment of the pain. So the importance of that, it's always in whatever the symptom it is, a proper history is needed. The history wise, you can get an idea what is causing this pain. So the importance of PQRST is because you know the site of the pain when it started, the features, whether it is a muscular pain or neuropathic pain. So this is a patient with advanced carcinoma pancreas. So neuropathic pain could be one reason. The visceral pain, the local invasion of the cancer could be the reason for the pain. Then the visceral pain has to be managed. At time, the nerves around that could also be intervened. Involved. So neuropathic pain could be a reason. So that can be cleared only with a proper history. That is why PQRST of the pain assessment is very important. So the patient, if the patient have a neuropathic pain, these medications are very limited role in neuropathic pain. The drugs needed for the neuropathic pain has to be added. Only then the pain can be managed. Or the drug could be, the disease could be causing a spinal cord compression or fracture spine if the disease already spread. So then the drug should be for the bone pain. So that is why the history is important. With the history, you can know what is causing the pain, identify what is the cause, correct the correctables, then manage. That is important. And coming to this prescription, morphine and tramadol, as Sister Shiva has already said, two classes of medications are mixed. Morphine, we usually don't, when we go from tramadol, if the patient is not having satisfied relief or any adverse effects or contraindications there, the patient is having severe pain, we go for morphine after stopping the tramadol. So mixing two classes of opioids can cause adverse effects of the opioids very easily. So it is always advised to stop the step 2 opioids and go for step 3. Okay, in paracetamol also, the dose is very low. The duration of action of paracetamol is 4 to 6 hours. So if the patient, you are looking for a round the clock pain relief, at least 6 hourly of paracetamol has to be given. I don't know why B-causules are added. One thing I want to add is Crimafin plus strategy. Crimafin plus sodium pycosulfate. So it's a stimulant laxative. That's one issue that we see with the brand names. Crimafin is liquid paraffin and sulfate, so it's a softener. But Crimafin plus may pycosulfate be, but the dose might be very low. HS dose, it's a combination drug, so you need more dose. The dose has to be increased if it's constipated. Over to you, Shubhasta.
Okay, so thank you for your wonderful clarification. I go back to the discussion points. Okay. So we already discussed what are the ways of reducing pain. As Dr. Arjun said, you have to do the proper assessment and try to manage with a non-pharmacological management, and then you can think about the pharmacological management. So always we should believe the patient word signed. If they are able to tell the pain score, you can use a numerical pain rating scale. That would be better assessment scale for pain. And if they are not able to give a pain score, then you can use a Wong-Baker scale also, as one of you mentioned in the chat. Usually we used for the children's group for that Wong-Baker scale. So we mostly prefer the numerical pain rating scale. And so what are the, yes.
Sorry to interfere. Sorry, it's always the patient knows the pain better. The patient is the best person to assess his own pain. So a patient numerical scale would be the ideal for assessing even any setting. Wong-Baker scale is used only when patient cannot express their own pain, usually for children, as Shiva sister said. And one more question, there's maximum dose of morphine. There is no maximum dose of morphine. The ideal dose of morphine would be, so there is no limit for morphine. We give the patient a dose with a satisfactory pain relief or at a dose lower than one which causes a adverse effect. Back to Shiva sister.
Okay, thank you. So, and the next question, what is the importance of non-pharmacological pain management and GA symptoms? We already discussed. Okay. So now the third question is, how can the family involved in all management and solve financial crisis? So, what do you all think? How can we involved? So we need the caregiver. So because if they are not willing to help the patient will not get that care from the caregiver. So we need a caregiver support. So without support, we can't do anything. So how can we involve them? So that we need to discuss. Any comments? Anybody have any idea?
मैम फाइनेंशियल क्राइसिस आयुष्मान के थ्रू भी तो सॉल्व हो सकती है ना, जो गवर्नमेंट ने स्कीम चलाई हुई है.
Okay. Any other problems?
जो ऑलरेडी पुअर फैमिलीज हैं कि वो आयुष्मान के थ्रू अपना ट्रीटमेंट किसी भी प्राइवेट हॉस्पिटल्स में चला सकती हैं जो ऑलरेडी गवर्नमेंट पैनल के अंडर हैं, और गवर्नमेंट हॉस्पिटल्स में भी आयुष्मान बेनिफिशियरी का ट्रीटमेंट एप्लीकेबल है, तो फाइनेंशियल क्राइसिस कैन आल्सो सॉल्व फ्रॉम दैट आयुष्मान मित्र benefits.
Okay, so now the financial crisis is taken care of, right?
यस मैम, फाइनेंशियली पेशेंट को उधर से अपने वो हेल्प मिल सकता है ना, कि उसको बेसिकली खुद से पैसा पे करने का टेंशन खत्म हो जाता है ना.
Okay, fine. Yeah, so yeah, as Sangeeta said, we can use these kind of support for their financial crisis. And also, I would like to hear from you, Mamta, who is the primary caregiver of this patient? Do you felt any difficulty to include the caregiver for involvement of the care or anything?
नो मैम, केयर गिवर तो है, बस इसका फाइनेंशियल क्राइसिस का था, वो आयुष्मान कार्ड इसका बन गया है जिसमें कीमोथेरेपी फ्री होएगी इसकी पेशेंट की.
Okay, so the next question is, how can the family be involved in all management? Is my question is, do you feel any difficulty to involve the family members to take care of the patient? Anything you felt that, or just a
नो मैम,
discussion?
his family member are very no ma'am, his family member are all are very supportive.
Very supportive. Okay, so if you felt these kind of reluctance, sometimes they will not be. They sometimes they refuse to take care of their patients. Maybe some kind of misconception will be there. We have to identify their insights. We need to explore their emotions too. Why they are reluctant to take care of the patient. If you feel these kind of things, what you can do is you have to sit down with them and listen their worry, and explore his emotions, explore their caregivers' emotions, so that you will get an idea why they are reluctant, so that we can give a clarification. And if they are sometimes they will be in anxious, so why how can I take care of the patient? If for example is in a wound, just one cancer wound, usually they will not come forward and okay, I will do these dressings from tomorrow itself. They don't usually like that. So we usually just sit down with them, and then we will ask them, do you have any problem? Is there any difficulty you feel? Then they will say, yes, we have a misconception. Maybe this disease to spread to me also. These kinds of misconception will be there always in their mind, no? So if you can listen and explore their problems, you can give a proper explanation. And if they have any difficulty or anxiety or any fear will be there, we usually bring the patient and caregivers together in the inpatient unit, and our nurses will teaching and demonstrating and gradually involve the patient care and all. Finally they will get used to do the dressing and all. So day by day they will learn little bit. Finally before discharge they will do everything. They will be able to do the dressing for their own, and then we will usually discharge the patient from the hospital. After that our home care team will do the follow up. So so these kind of things you have to
Ma'am, I have a question in family involvement.
yes. Ankita, yeah, do you have any questions?
मैम एक्चुअली लास्ट वीक एक पेशेंट आए थे ओपीडी में, एंड उन पेशेंट का जो प्राइमरी केयर गिवर था वो उनका बेटा था, एंड उनका बेसिकली ये था कि लाइक वो जब ओंकोलॉजिस्ट के पास है, उन्होंने सिर्फ एक क्वेश्चन बोला कि जो पेशेंट है उसको मत बताना.
Ankita, can you speak in English?
Yeah, okay. Actually, ma'am, last week a patient came to the OPD and he said to the oncologist that don't say anything to the patient about the cancer, because we can't we can't able to know her that she has cancer. So in that condition, what can we do? How can we tell to the patient that she is suffering from this disease condition?
Okay, what is the situation called? So we already learned from the last week sessions, I think.
Communication over,
Yeah,
sister.
yes. Communication is over. That's why I asked that question. So what is the situation called? That is a collusion, right? Shani ma'am said, there is a collusion. So how can we break the collusion? If the patient is, why they are collude? So we need to understand from the caregiver side. Okay, we need to.
Ma'am, the primary caregiver was like, if anything is done to the patient, that is fully your responsibility. We don't take any responsibility for that.
Okay. Then you can sit with him and ask them why you are telling like this. Is there any problem behind that? Is that question?
No, ma'am.
Yeah, your sound is breaking. Your voice is breaking. Angita, we can't hear anything. Dr. Arjun, so
Yes.
there
So
is a collusion.
Ankita online.
Yeah. So Ankita is there, but not responding. If there is a collusion there, so this is the way. No, we have to understand the emotions and understand their why they are collude, and then we can gradually understand. We have to set them. This is very important. She needs to understand the disease, because now her or his health condition is okay, but after 2 weeks we don't know this health condition is improving or worsening. So that is that thing we should tell the caregivers. Without caregivers consent, we won't be able to tell. That is one of the truth. Do you agree, Dr. Arjun?
Yes, exactly. First thing that I think we should do in this situation is agree to collide. The primary caregiver says you want a collusion. You agree with the collusion. Tell them that you won't tell to the patient unless you agree. But before that, we have to talk to him. Ask him why he is afraid to talk to them. Many a times they might be saying the patient condition might worse when they hear the news, or some other things would be there. So many, it's usually a wrong thing. Like if it is my body, something happening in my body, I am the affected person. I would definitely like to know what is happening to me. So I have the right to, and I want to know what's happening to me, or multiple issues can occur. So talk to them about benefits of the adverse effects of coalition, how it can benefit if we break the coalition to the family. Like sometimes she might be having some unfinished business. The patient might want to meet some old friend, write a living will, sorry, write a will, or some a temple she want to visit, or mosque or church she want to visit. But if she understands that she is nearing end or the disease is progressing, she might be able to fulfill her wish. So something that might be done at the early stage when before she become bedbound, or so such thing can occur. Or there could be issues with communication. The poor mother might be asking the son, what is happening with me? What is happening with me? I am getting more sicker. The son who knows the truth won't be able to talk to mother, so he might often neglect the questions. So that might add on to a communication gap between the family. Sometimes she might be having bad symptoms, but the doctor and the family might be knowing the symptoms cannot be controlled because of advanced disease. But she doesn't know that she's having the disease, so she will say she might be, you are not, the family is not taking care of her, or the medical team, the doctor or the nurse are not providing her adequate care. So she will ask them to take her to the hospital. The family cannot tell her the truth, but they will go for the hospital. The hospital handling, more resources has to be spent. So many issues are there. Convince the family why it has to be conveyed to the patient, and once they agree, we can raise the coalition.
Okay, sir. Thank you.
Yeah, and also you should tell them if even if you say yes, okay, we can that break the news, we will do it in a proper way. No, all of a sudden you have a cancer. Don't like that. We have a protocol. We last week we learned about the spice protocol. We can use that protocol for breaking the bad news. So this way we will give a that warning shot like that. Only we will be going to the break the bad news to your loved one. That also we can give an assurance like that. Then they will agree.
Okay, ma'am. Thank you.
Okay. Any other questions? So I think no more questions. Can we wind up, Dr. Arjun?
Yes, please, sister.
Okay. Thank
Thank
you,
you, everyone.
Dr.
Thank you.
Thank you,
Thank
Dr.
you for the
Arjun.
Thank you,
wonderful
ma'am.
session.
Thank you, sir.
The wonderful session. We have learned many things today. So please keep it in mind while we take care of this kind of patients, especially nausea and vomiting, one of the that important symptoms, because we need to take care of that part. And always you have to look into the non-pharmacological measures, and then you can think about the pharmacological measures. And as Mamta presented, this is one of the excellent patient story, but again, you have to think about the medications. If the two drugs combines not required, then you have to inform the doctor. So is it required two drugs together, and that kind of things you have to communicate is a proper way. Communication, we learned how to communicate, and also how to do that do it in a proper way. So we are uh, we are here to take care of the patient also. If you noticed these kind of mistakes in the prescriptions, please give attention to that, and convey this to the concerned doctors. Okay, so that is also important. And thank you once again, Mamta, for the wonderful patient story. Thank you for your answers. Thank you for your contributions and all. Thank you, Dr. Arjun, once again. Thank you.
Thank you, Dr. Arjun, for the wonderful case presentation. Thank you, Shiva ma'am, for presentation. Thank you, Mamta, for presenting a wonderful case story. Thank you all for participating actively in this section. Thank you. We will see you in the next session. Bye.